Private to the first hurdle, let me tell you that if you think about it, medicine is all about predicting. You're a doctor, you have a patient who shows certain sign in front of you, and you to decide the best course of action. You can tap in two things: the knowledge that you have accumulated over the years, and the information that you and your peers have accumulated primarily through experience, which allow you to find in the past a group of patients who showed similar sign, and when treated in a certain way, they got better. And by establishing this analogy, you predict the best course of action for this patient, and then, like every time you do a prediction, you see what happens afterward. Now, from the ancient times to the traditional medicine, to the 19th century revolution, and still today in most of the developing country, all this happens with a lot less information than it would be necessary. Actually, doctors are trained to take difficult decisions with insufficient information. So it is a bit of a paradox that in the last 20 years, primarily because of healthcare technologies, doctors are experiencing an information overflow. Medical imaging, genomic and post-genomic, the automation of laboratory testing that allow you to produce for a few pounds dozen of different blood and urine exams, and the explosive development of biomedical experimentation can and do generate enormous amount of information about each patient, which the doctor struggle to integrate into an informed decision. About 15 years ago, a group of visionary, sounds good, started to believe that following the example of other domains, we could imagine to use modeling and simulation to combine the available knowledge and the available information on each patient to support the decision of medical professionals. But it became also immediately clear that in order to do that, we first needed to establish a framework of methods and technology that at that time was not available. In 2005, a group of European researchers gave to this framework the name of virtual physiological human. Other communities use a different name. Japanese call it in silico medicine. Americans call it modeling in healthcare, but the concept is pretty much the same. And in fact, if you look in PubMed, the number of publications with the string subject-specific computer models, it goes exponentially up, starting from about 2005. To be honest, the beginning of the story happened a little bit earlier, in the early 2000s, when Peter Hunter, Jim Bassewitz, and a few others started the Physiome project. But whereas the Physiome project idea was to use modeling and simulation to build the physiome, which mapped the equivalent of the genome for the human physiology, the virtual physiological human from the very beginning was focused on the healthcare application. We wanted to develop technology that could support the medical decision. In 2007, we published this roadmap, seeding the Europhysiome, where we suggested a line of travel. You know, we started to define what this framework of method and technology would require in order to address this problem. The area started to develop very quickly, also thanks to some generous funding from the European Commission in the 7th Framework Program. And in 2010, we established the VPH Institute, which is an international not-for-profit organization that represents this emerging community worldwide. In 2011, I moved in UK at the University of Sheffield, and in May 2012, we opened the door of the Insignio Institute of in silico medicine, which we believe is currently the largest research institute dedicated to these topics in Europe. In the meanwhile, a couple of seed events happened which show that we are not completely crazy. In 2011, the FDA approved for the first time the replacement of an animal experimentation with a computer simulation in the case of preclinical testing of artificial pancreas technologies. Before that, the FDA required the technology to be tested on at least 10 dogs, if I remember correctly. Boris Kovacek and Claudio Cobelli showed that their diabetes simulator, the so-called Padova University of Virginia diabetes simulator, was actually predicting better than the 10 dogs experiment how a technology would behave in human, which is not surprising if you think about it. And the FDA got convinced and for the first time authorized this type of replacement. Now the idea of replacing animal experimentation with in silico technology is becoming quite a mainstream idea. And the second important event, and again I'm citing FDA not because I'm particularly America-centric, but I have to admit that FDA has been leading this area in terms of regulatory openness compared to the European regulators. In 2014, FDA approved for full commercialization HeartFlow, which is the first subject-specific modeling technology available clinically in every hospital in the United States. I told you about Insignia. Insignia from the very beginning started as a joint collaboration of the University of Sheffield and the Sheffield Teaching Hospital, one of the largest NHS trusts in UK. And the reason is because even in Insignia, from the very beginning, our intention was to keep the site of the clinical translation. We grew very quickly. These are the figures of our last year report, which are now a little bit outdated. But Insignia coordinated 140 academics or clinical researchers sitting in 28 different department or clinical directorates. So interdisciplinarity is massive. And we work on over 180 projects on broadly different areas, all related to in silico medicine. Now, if you're curious about knowing more about what's going on in Insignia, let me invite you to our annual showcase. Every year, we dedicate one day to present to our friends, to our funders, to our partners, all our results. This year will be in May 11th, and it will be our 5th birthday, so it's a bit of a special event, so I hope to see you some. The event is free, is open, you just need to register so we don't miss completely the catering. So how do we define in silico medicine? Well, there are many ways, but one that I like particularly is by categories of users, and I will use this today as a structure in my narrative. So far we have identified 3 groups of users. We call digital patient the in silico technologies that have the end user a doctor, typically a specialist in a secondary care setting. We call in silico clinical trials technologies used both in the clinical but also in the preclinical, so the name is slightly misleading, to assess the safety and the efficacy of new biomedical products. So typically the end user is someone developing a new product in an industry. And the third is personal health forecasting, which is the use of this subject-specific model in combination with mobile and digital health technology to feed back to the patient, citizen, user directly information useful for self-management of his health status. So let's see some of this with some detail. And let's start from the last one. This is probably the least mature of the 3, but is developing very rapidly, driven by 2 facts. First, by 2020, we expect 65% of the world population to be covered by a 4G network, at least. And almost 90% to cover to some sort of mobile network, okay? So we can start to believe, we can start to assume that mobile connectivity is ubiquitous, and to a large extent it has considerable bandwidth. The other, which is kind of neglected, I believe, but I think is an enormously important trend, is that consumer electronic industry has discovered healthcare. These are just 9 random products that I picked from the many, many healthcare-related products that were presented this year at the CES event, the Consumer Electronics Show in Las Vegas. Some of the stuff are really amazing. But the things that, for me, makes them very important are 2 characteristics. First, they're very cheap. Well, not necessarily cheap to buy, but they are very cheap to manufacture in large volume. So the day we want one of these things to be produced in 1 million copies, it can be produced at a few pounds each. Secondly, they are very well designed to be used not by a medical professional and still provide some decent information. And that is huge, and I'm sure many of you know how difficult this is. So if you combine the 2 things, suddenly the whole idea of telemedicine starts to become a much more serious scenario. And in fact, there is a number of experiments that are developing, in particular in rural areas, in developing countries, where the access to healthcare infrastructure is extremely difficult for various reasons. This technology allows to keep a community monitor from a healthcare point of view with minimal cost and with a good interface with specialistic care remotely. Now, where is the in silico modeling here? Well, no matter how good are your wearable sensor, your portable technology, they will never provide you all the information that you would get if the patient is in the hospital. But if the patient came to the hospital once and you collected enough information to build a subject-specific model, and then you combine that with the few data that the wearable sensor can provide you, the combination of the 2 can actually be sufficient to most diagnostic exercise. This is our theory. The picture here represents one initial example. This is, I'm sure you're familiar with this type of technology. These are accelerometer used for activity monitor. They don't give a lot of information and tends to be very noisy. But if you combine with a subject-specific model, you can actually get some very good estimate, for example, of the ground reaction force, which is something that you typically would measure accurately only in a gait analysis laboratory setting, in a clinical gait analysis lab. The other scenario that we are interested in is that of monitoring of progressive conditions. Imagine, I don't know if you're familiar with this device. Essentially, you mount the shell behind your iPhone, you hold it, and it makes a single channel EEG. It's pretty cool, actually. It's quite impressive. But what do you do with a single channel EEG? I mean, well, of course, arrhythmia, there are certain scenarios where this makes sense, but there are many others where the information is not enough. But imagine that you can couple this to a subject-specific circulatory model and use the alteration in the EEG to predict how a particular condition, for example, a subclinical abdominal aneurysm is progressing, and when it might be the time to bring back the patient in the hospital for a check, okay? It's a bit futuristic, but we're getting there. In silico clinical trials, I don't know if you're familiar with this figure. It was published a couple of years ago. Apparently, to bring a blockbuster drug to the market today, Big Pharma spent around $2.5 billion. I believe that this is a ridiculous number. And there is really no reason why innovations should be so expensive. Why is that? Well, there are many reasons, but let me offer you one. So let's say that you're developing a new large carrier like this one, or a nuclear power station, okay? And the only way to test the safety of these things is that you build a few copies, you put it around the world, and you watch to see if any blows, and if they don't, it means they're safe. That is a clinical trial. Cannot believe that we cannot do a little bit better than that. I mean, each of these data today, before the first piece of metal is cut, as being tested and retested for an infinite number of scenarios through modeling and simulation. Why cannot we do this also for drugs, for medical devices, for biologics? It sounds obvious, but until a few years ago, almost every regulator refused modeling and simulation as an evidence, by principle. This is why a few years ago, together with a group of friends, we started this initiative, the Avicenna Support Action, which produced this roadmap. It was a massive effort. This roadmap was collaboratively written by more than 600 experts from clinician, industry, academia, from all over the world. Believe me, coordinating 600 people with one pen is not easy. But we manage. And I have to say, for the first time in my life, I can say that this type of work produced an impact in terms of change of policy. Because in the span of less than 1 year, the two largest parliaments of the two largest healthcare markets in the world, United States and Europe, made a very similar recommendation to their regulator. You must start to use modeling and simulation in your safety and efficacy assessment processes. And now the regulators are complaining. And there is a whole series of things that are happening both at the FDA and the EMA. Things are still fluid. It's very confusing. But now everybody agrees that this is going to happen. How? What are the details? We still don't know, but it's going to happen. Now, one interesting angle that comes almost like a byproduct of this thinking, but which in some European countries is becoming very, very important, is that with this type of technologies, you can also reduce, refine, and partially replace animal experimentation. And if you think that the Netherlands, for example, has decided by law that in a few years they will have to go down at 0 animal experimentation, which I think is a bold decision, you understand how important this is going to be. Okay? This picture represents a pipeline that we developed in Sheffield, where we use virtual physiological human technologies on mice instead of humans. Okay? And by using this technology, we were able to demonstrate that in the testing of bone drugs, we could reduce of 60% the number of animals that are required to achieve the same statistical significance, just by refining the method. But we also produced something else. Historically, this animal model produced an information that is not the bone strength, which is what you would like to know, but it's something that is vaguely correlated to the bone strength. And if you really want the bone strength, you have to sacrifice the animal, harvest the tibia, break it, and then you get a number. But of course, it's not a longitudinal, it's a cross-sectional. With this technology, we can actually have an in silico estimate with an accuracy of 85% or better of the bone strength in vivo, longitudinally. And this is a much more accurate predictor of what is going to happen in the human than the previous indicator. But it's not enough. I mean, we were reducing animal experimentation. To some extent, we're refining because we are using some of this in silico technology to remove some of the procedure that induce more suffering to the animals. But I believe there is an opportunity for partial replacement. If, for example, in every study of this kind, there is always a wild-type arm, a group of wild-type animal that are treated with placebo, and every time you repeat the same thing, okay? If we can start to develop a model of the response of those animals under those given conditions, which is proven to be accurately predictive, we don't need to run the animal bunch every time. We just replace that arm with an in silico simulation, okay? And then, this is really my dream. There is virtually nothing here, but I don't know if you know, but out of 5 drugs that pass the preclinical test on animal, 4 will not work on the human. They will fail the clinical trial at one of the stages. So this animal testing is not working, okay? And one of the reasons is because it's very difficult to quantitatively correlate what you see on the animal with respect to what you would see in the human when you perform the same intervention, okay? Now, I believe that this technology could actually, for the first time, offer a one-to-one quantification of the same physiological process in the animal, in the human, so that you can finally quantitatively say this animal model is a good model of what is happening in the human or not. The last is the digital patient, which honestly is the first because that's where we started from 15, 20 years ago. A little bit of self-advertisement. A year ago, I was asked to contribute. They put me at the very bottom, but that's fine, to this pamphlet, which is available online if you're interested, where they ask a number of experts from very different backgrounds to discuss, from their point of view, a big problem, which is the long-term sustainability of the universal healthcare model in the United Kingdom. Very complicated topic, very political, but there are some facts that are unquestionable. The first is that the population in UK, like in most developed countries, is getting older. And that means that the amount of healthcare that we have to provide is increasing. And so this is bringing the expenditure at level never seen before. Everybody tell you this, but very few people tell you this. The other problem is that we've been very good in our job. So there is a number of conditions that were killing people, and now we can cure them, but we can keep them diseased for a very, very long time. We can keep them chronic. And these people consume an enormous amount of healthcare. So believe me, if you look at the number carefully, aging, yes, it's important, but it's only half of the story. There are a large number of cancer that were fatal to 80% of the patient within 12 months. Today, they have survivorship over 5 years. But these are not easy survivorship. They require continued treatment, okay? Now, these two events are creating a lot of pressure on every universal healthcare system, okay? What are the solutions? Well, of course, everyone has a different opinion, but if you look at the debate, there are a few ideas that are coming again and again. Okay? A big problem is multimorbidity. Because of both reasons, you end up with a lot of patients that come to the hospital not with one disease and for the rest they're healthy, but with many different diseases. And that called for a much more personalized medicine, where you're actually able to look the patient more in its complexity and choose the best course of treatment, keeping in account this multimorbidity. The fact that we have such a large number of chronic patients, and this is not only related to this, it's also related to the aging, impose that we have to do much more for prevention. I still struggle with your beautiful language. There is an expression in Italian and in French which I couldn't really find a proper translation in English. The best I found is futile care, but I'm not sure it does really convey. In Italian is accanimento terapeutico. It means that you are treating the patient beyond what is proper. Okay? I'm talking primarily about end-of-life decisions. Okay? This is a very complicated topic, but I think everybody agrees that one good solution would be to increase the participation of the patient, him or herself, into this type of decision. Okay? Now, why I'm telling you all this? Well, because this is called the 4P medicine, but those are 3P, so where's the fourth? Well, if you can predict how a given intervention will change the health status of that given patient, which is what I've been talking about till now, then you can personalize the therapy by simulating different options and choose the one that actually works better for that multimorbid patient, for example. You can explore which changes in lifestyle, environmental condition, etc., may help to prevent certain condition or reduce the degree of chronicities. and help you to engage the patient. Because, you know, everybody talk about participation, but it's a classic when you have geriatric oncology, you know. You say, well, if we treat you, it's going to be difficult, it's going to be painful, and if you don't treat me, we don't know, you could die tomorrow, you could die in 5 years. Well, that's a tough decision to take. But if we were able to start to provide a bit more informed with different scenario, then the participation of the patient could become a little bit more realistic. Now, let me show you some example of what we're doing in Sheffield. And by no means, we are not the only one in the world working on these things. And there is a lot of beautiful and exciting development all over the United Kingdom and all over the world. A lot of cardiac condition turn out to be a coronary stenosis. That means that the blood vessels that are wrapping your heart, the coronaries, get a narrowing. You find out that you have a coronary stenosis because they bring you to the hospital and they do this type of imaging, okay? And based on this imaging, the doctor should decide what is the best course of treatment, given a number of different options nowadays. Now, it is being proven quite conclusively that the best way to decide to stratify by treatment in this patient is to use a single measurement called fractional flow reserve. Unfortunately, FFR, it's an invasive measurement, it's expensive, involves a few risks, but more important, it can be performed only in relatively specialized centers. So as a result, in UK today, only a few % of the coronary stenosis patients are actually stratified with FFR, in spite everybody agrees this is the best standard of care. Julian Gunn and Paul Morris, Rodos, have started to develop on a apparently simple, extremely complicated idea, take these images that we use in diagnosis and build a subject-specific model that can predict FFR non-invasively. And they succeeded. The VIRTUheart technology is being now accurately tested in a clinical trial over 200 patients. The accuracy with respect to the actual physical measurement is amazing. But it now opens other scenarios, because once you have the virtual model, you can also start to simulate, for example, different intervention and see which one would actually solve, for example, complex scenario where you have multiple stenotic lesions and you need to decide which one is the best to treat first. Jim Wild is an MRI specialist who has developed this amazing technology called Polaris that allows to obtain incredibly detailed MRI pictures of the lungs. And this technology are now combined with subject-specific modeling, for example, to do differential diagnosis of pulmonary hypertension. I don't know if you know, but the north of England, in particular Sheffield, is an area of major prevalence of pulmonary hypertension. Don't ask me why, I have no idea. So our hospital has one of the largest cohort in UK. Over 5,000 patients are being constantly monitored for pulmonary hypertension. And it's an incredibly difficult disease to do a differential diagnosis, because it could be the heart, it could be the lung, it could be the artery connecting the two. And with this technology, we're now able to obtain a very accurate stratification, again, without any invasive procedure. A huge number of people in the world suffer lower back pain. And when it's time to decide what is the treatment, everything gets very, very foggy. The MindSpine project, led by Damien Lacroix, explored over 200 patients and showed that by using subject-specific modeling, we can actually support the decision whether to prescribe conservative treatment or two different surgical procedures, discectomy or spinal fusion, which are more and more severe, in a much more accurate and reliable way. Shannon Lee has developed one of the few biomechanics simulation of childbirth in the world. What you're seeing here is the head of the baby passing through the pelvic floor muscle. The reason we're now interested to this in insignia is that by using this simulation technology, we're now trying to predict in which cases the birth, the natural birth, will produce a damage to the pelvic floor. It's an interesting situation. A lot of women have a damage to the pelvic floor, which apparently repair after the birth, and they remain completely asymptomatic until they start to have 56 years old. And then they have a number of problems like prolapse, urinary or fecal incontinence. And there is strong evidence that roll back to this damage. So if we could understand which are the women at risk, we could choose a therapeutic cesarean, for example, or use other approaches to try to minimize the damage. Juvenile idiopathic arthritis is probably one of the most complicated diseases I ever dealt in my life. I don't know if you know, but idiopathic means I don't have a clue of what it is, okay? So it is an arthritis. It affects children. It's not rheumatoid. That's all we know. In some patients, you give a mild anti-inflammatory, it goes away, never comes back. In some patients, you have to use chemotherapies before you can stop the inflammation response with massive lesion to the cartilage and very severe impairment over the life of the child. We're part of a European consortium that is looking at this disease from very different angle. And in Sheffield, we're responsible for the anatomo-functional determinant, the biomechanics, okay? And we just pull out the preliminary result after 4 years of data collection. And I'm glad to say that immune produces zero significance. Inflammatory cytokine produces zero significance. We have 5 biomechanic parameters that are statistically significant. So it suggests there is a basis here that is worth to be investigated. In a number of situations, you would want to know how big is the force that is required to break a bone, a given bone, a femur, for example, okay? Forensic. Now, if the bone is of a adult, I can tell you, if you tell me if you're a male or a female, how tall you are, I can give you a number that is 10, 20% accurate. Why? Because for many, many years, the bone biomechanics community had access to cadavers in the donation program, from which cadavers we harvest bone, and then we broke them, and we measured the strength. But no one donates children's body to donation programs. So as much as we know about adult bone, we know nothing about the strength of infant bones in particular. Now, you're a pediatric radiology, like this lady here, Amaka Ofia, our pediatric radiologist in Sheffield, and a child comes in with a fracture, and the carer tells you how this happened. And the story doesn't really match with the fracture. This is called an unexplained fracture. If this is true, there are 2 scenarios. First, the child has a disease, a hidden disease that is weakening the skeleton. Very rare, like osteogenesis imperfecta, but it's possible. Or that child is experiencing an abuse. But before you say anything like that, you'd like to be sure. And we don't know how big is the force that breaks a bone of a child. So Amaka started to convince parents who lost their children to perform post-mortem CT scans. And we're using subject-specific technologies to actually estimate the strength of the children and building a reference database, which will be the first in the world, by using non-invasive methods. So we respect the body of these children. We don't desecrate their body. We get the permission from a family, but we are accumulating data. And now we started to collaborate also with Great Ormond Street around this project. Okay, last 10 minutes, right? Yeah. So I would like to finish by being very superficial. I wanted to give you a big picture, and at the risk of sounding a little bit fluffy. So let me finish by telling you a little bit more in depth 2 stories from my own research area. My area of expertise is in neuromusculoskeletal modeling. So I will present you 2 cases. The first is actually the first time I developed a subject-specific model many years ago. And the second is the most recent result that we obtained on an important adult application. So there is a rare tumor called Ewing sarcoma, which attacks mineralized tissue. The good news is that the mortality rate for Ewing sarcoma nowadays is relatively low. The bad news is that it attacks almost exclusively children and adolescents. It's a pediatric tumor. The first thing you have to do when a child has a Ewing sarcoma, you have to cut away the tumor. And that usually implies to produce a massive defect in a load-bearing portion of the skeleton, like the femur, the tibia. Now, if this was an adult, it wouldn't be a problem. You would replace the massive defect with a prosthetic device, maybe a custom-made one, and everything would work fine. This is a child. The rest of the skeleton will grow throughout his life, but the prosthetic device will not. So how do you do? There are a number of solutions, but one that was developed in the hospital where we're working in Italy, the Rizzoli Institute, before moving to Sheffield, use bone bank, cadaver bone, decellularized. They develop an allograft that is inserted with an autotransplant of a vascularized fibula from the same child and then stabilized in place to reconstruct the defect. And if everything, and the blood supply is locally reconnected to a femoral artery. If everything works well, the internal living bone will rehab it because of the enormous osteogenic potential of children. This would never work in an adult, but in a 3-year-old child, if everything works fine, in a few years, this will become a perfectly consolidated, living, growing bone. It's quite amazing, actually. Believe it or not, the problem is not the surgery. It's a very challenging surgery, but this can be performed quite reliably. And in Bologna, at the Rizzoli Institute, they perform about 60 of this procedure every year. The problem is the rehabilitation. After this surgery, you have a child that has a femur or a tibia that is made half of a piece of cadaver bone, a piece of autotransplanted bone that will grow eventually, and a metal plate that keeps everything together. What is the maximum load to failure to that complex? God knows. But that's an important information because you have in front of you a 5-year-old child. If you don't start to rehabilitate immediately, there will be some development issue. Children requires to load the skeleton as they grow. If you don't, they will have problems. But if you load too much during the rehabilitation, you will fracture the reconstruction, and frequently the only option at that point is the amputation of the limb. So it's a very difficult choice. And the team that deal with the rehabilitation in Bologna were really struggling with these children. The rehabilitation is very simple. They put them in a pool with the water very high at the beginning, and they ask them to walk, and then they progressively lower the water. So the decision was how quickly you lower the water has the reconstruction heal. It seems like an easy question, but it was very difficult. We started to look in this, and the first thing we realized is that obviously the surgeon didn't only change the skeleton, it also changed all the muscle that were attached to that, which were reinserted, moved, etc. So we started to develop this whole body subject-specific model using these techniques where we place marker on the patient, we perform medical imaging, but this marker are reflective. So then without moving them, we bring the patient in the gait lab, we perform a full gait analysis, and we can use the skin marker as a co-registration framework to combine the anatomical detail of the CT or MRI data sets with the functional information coming from the gait analysis. And when we do this, we could build a model like this that could predict with a certain amount of accuracy the forces being transferred to the skeleton during the rehabilitation exercise with the given level of water. And then we build a finite element model for the reconstructed bone and a contralateral of the contralateral to use it as a control. At that time, this technology was very, very immature, so it was really building the bicycle while you were riding to some extent. But somehow we managed to obtain a reasonably accurate result. And we started to follow up patients. This is the patient that we follow up for the longest time for a number of reasons. We followed for 4 years. And this what happened to this child in the reconstructed. He had a distal femur Ewing sarcoma, so the 2/3 of the distal femur were resected and reconstructed with this technique. You see, in these 4 years, the body weight of the child went from 30 to 48 kilograms, but also if you notice, the picture is in scale, the femur became significantly longer, okay? The child is still growing, okay? The growth plates are open and the child is growing. I want to show you a detail. You see here, here it was dark, here is white. Actually here there was a screw, but when we analyzed this result, together with the surgeon, we decided that that screw was creating an excessive stress shielding in that region, and so we decided to remove it, and the surgeon removed it, the screw, and actually we got the response that we wanted. So not only it was used to plan the rehabilitation, but it also assisted in this particular case to perform the surgery. So this is how I got into this business many years ago. Now let me change completely subject. And from the children, let's go to the elder. An old lady is walking along the street. She's perfectly fine, but at one point she has a little trip, she falls, but it's a minor fall. But for some reason, she feels an enormous pain. She's taken to the hospital, fracture of the hip. But the fall would not produce such a damage. Well, this lady has osteoporosis. With the aging, it is physiological that we lose bone and muscle mass. But in this patient, the speed of this loss is pathologically high. And it becomes so rarefied that bone tissue, that the ability to withstand mechanical load, it gets severely compromised. What you see here is the standard of care adopted in most European countries nowadays. If you're considered the general risk, you go to the visit of a specialist, and they examine you with this machine called bone densitometry. The technical name is dual X-ray absorptiometry, or DXA, which essentially measure how much bone you have in your body in kilograms, okay? Which, if you're an engineer, is like saying how strong is the bridge by telling how many tons of steel I used to build it. It's not enough information. And so, not surprisingly, if this number is low, we treat. If it's high, we don't treat. And in both arms, about half of the patient will fracture anyway, which is pretty bad, okay? So large room for an improvement, one would say. Well, in 1990, it was suggested that if we had a CT scan, we could actually develop a subject-specific model, a finite element model, that could predict accurately the strength of the bone, non-invasively, which sounded perfect. In reality, it turned out a lot more difficult than we thought. I was already around in 1990, and believe me, we were very naive. Today, the technology we develop in Sheffield is called CT2S, and is the result of a very long and painful process. First, we had to develop a reliable experiment to validate the model. And it took us a number of years to obtain the level of accuracy that it was required to validate these models, okay? Measuring the strength of a piece of metal, it's not that easy. Believe me, measuring the strength of a human bone is a lot more complicated. What you're seeing here is one of the experiments that we developed at the end of this long process, is a human cadaver femur that is loaded to failure while it's covered by a large number of strain gauges. We are measuring the force, the displacement, the strain in about 80 different points with rosette. And then, these are not 3 femurs, 2 mirrors. We're using high-speed cinematography and the 2 mirrors to do a stereophotogrammetric location of the point of initiation of the fracture. So not only we validate the model with the load to failure, but also where actually the model predicted the failure to happen compared to the experiment. So when we finally had this model experiment to be reliable, we started to improve our model. And at the beginning, the model, believe me, were really, really bad. But eventually, over a shorter period, I have to say, but still a few years, we managed to get it right, okay? And if we were in a traditional engineering domain, that would be the end of it. My model predicts accurately my in vitro experiment. But in healthcare, this is not enough. So when I came to Sheffield, we started to test this technology on a cohort of 100 patients to obtain the clinical accuracy. And this is what we just recently finished, demonstrating that this technology has a higher, not much to be honest, a higher accuracy than the standard of care, the bone density measured with densitometry. And even if the improvement is not huge, it makes an enormous difference in clinical study. So if you measure bone strength, say that you are running a clinical study to evaluate the effect of an intervention, a drug, a physical exercise, on the strengthening of the skeleton, say the femur, okay? You measure indirectly the strength through the bone mineral density. The accuracy is about 75%. In order to discriminate between the intervention and the placebo, a difference of about 20%, power calculations suggest you need 250 patients, okay? Which, depending on how the trial is designed nowadays, can cost between 140,000 to 1.2 million, depending on the complexity of the trial. By switching to the C2S technology, which has an accuracy of 82%, so it's only 7% better, it's not hugely better, okay? Under identical condition, your cohort can be only 127 patients. And that first makes much easier to recruit 100 patients than 200s. Believe me, but also it offers a saving, depending on the design, that goes between 30 and 50% of the trial cost, okay? So in this scenario, we think that even this relatively small improvement is entirely justified. And that's why we recently made available this technology as an online service, so every hospital in the world who wants to run these clinical trials can upload their anonymized CT scan, and we will get the prediction of strength within 48 hours. I'm going toward the end. If you want to know more about this type of stuff, hands-on, there is a cool thing we organize in Sheffield every year. It's called the Modelathon. I'm sure you heard about the hackathon, these things where software developers lock themselves away. Well, it's pretty much the same thing. We give you a bunch of data, we divide you in teams, and we challenge you to build a subject-specific model in 48 hours. You can work day and night. You have all possible software tools that you can desire. It's a lot of fun. If you're interested, just register. It's free, it's open, and it's really, really interesting. And you learn a lot. We have a lot of representatives from the software industry. There are experts there that teach you how to best use the software while you do things, so it's fun. So, in conclusion, subject-specific modeling is here to stay, I believe. I hope I convinced. If I didn't, I was not a good preacher. The first model are very, very difficult to develop. Beginning are always hard. But now that we are, in some cases, doing the second cycle, so we try to solve a similar problem, it gets a lot easier. So my expectation is that in the next few years we will see an exponential growth because the cycle to innovate will become much shorter. One thing we're not doing, and I think we must do as a community, is to focus on the sustainability of universal health care. Until now, this technology has been targeting the most difficult clinical situations, ignoring the cost issue. I believe there is also a case for using this technology not to improve the standard of care, but to reduce the cost associated to the standard of care, so to making the care more widely accessible. I hope I convinced you that this is an interesting area, but if you want to find motivation, you remember the child that we follow up for 4 years. Well, a year after the end of this study, he was skiing downslope in the Alps. Now he's an adolescent in this movie, but he's perfectly fine and is having an absolutely normal life. And I believe we all do this job primarily because of this. Thank you very much.
Thank you, Mark, for a fascinating and inspiring talk. We have now 15 minutes or so for questions. Poppy has a mic if anyone wants to ask something. which I'm pretty sure you will. Okay, Will.
Your mic?
Yeah, it's coming.
Thank you. This is kind of off the wall question, but of course there are many parts of the world where domesticated animals are extremely important. And you talk about avoiding animals, and indeed my cousin who's a horse vet will point out that horse races are valued more than people anyway. I'm wondering, is there any effort to apply this to animals as well as people?
Yes. The short answer is yes. And thoroughbred is one obvious target. If you can understand what's wrong in one leg of a racing horse a week before what is now, it means million in some cases. So yes, there are scenarios of this kind.
I was wondering if you could advise if one wanted to become more knowledgeable in the subject and actually begin to study it, because I have no prior expertise in this field. Where would you start to begin to study and learn how to create these models?
One of the things that makes this area difficult is that you cannot develop skills that are general purpose. You remember when I introduced myself earlier on, I said I'm a specialist in neuromusculoskeletal modeling, which means I don't do cardiovascular modeling. He does. And he's not doing any modeling of musculoskeletal. And neither me or him do anything about internal organs. So this is because while many of the technologies are similar, in order to be effective, you have to have a deep understanding of the physiology and the pathology. And that at most can be in one organ system. I mean, there are a few geniuses like Peter Hunter that know everything about everything, but we mere mortals. So the first thing is you need to pick an area, okay?
I was wondering in particular about applications in epidemiology and looking at populations as much as individual models, for instance.
Well, thank you for this question, because in the strategic roadmap of Insignia, there is a fourth application that I didn't touch today. And the reason is because we've done ZIT until now on that. And it's this. The idea is that if you can start to have enough subject-specific model to build virtual population, then you could start to use this population model, but these are not statistical models, they are individual collection of individual models, okay, and make public health question, for example, or policy question. Is it better to do this or that? I think that before this become a realistic scenario, we need to have very large collection of subject-specific models. Until now, some of the best groups in the world have, what, 200, 300 subject-specific models in a very special. We need one order of magnitude more. So when we will start to have 1,000 subject-specific models, that scenario will become realistic. It's not going to happen in a long while.
Thank you, Marco. It's quite cheap to produce models these days because computing power is great and you can sit in a room and produce these models. But for a lot of the examples that you've given, you need to have quite sophisticated imaging techniques, or you have to use sophisticated motion capture techniques, and not everybody has access to that. So what's the solution to that? Because you need the subject-specific models in order to take it forward, but not everybody has access to that. And it costs a lot.
Yeah, it depends. So let me take a practical example. I show you a slide about the study we're doing on juvenile idiopathic arthritis, okay? Because we didn't have a clue, we analyzed 175 variables. Okay, anatomical, functional, obtained from simulation, electromyography. We shoot in the dark in every possible direction, okay? Most of them are completely useless. Interestingly, some of those who were useful could actually be generated with excellent accuracy with much simpler models. So what I'm saying is, it's true that when we present this first generation technology, we imply a technological infrastructure that is not available everywhere. But once the problem is nailed down, it's not crazy to imagine that you can replace a full gait analysis with a single well-designed dynamometric measurement, or a wearable sensor, or a full body MRI with a biplanar or low X-ray imaging technology, which are much cheaper, much more available. But it's another cycle in the development. I mean.
So I suppose, and I know from personal experience, the resource that's required to develop subject-specific models is very great, especially if you're looking at lots of different factors. So I suppose I'm trying to understand what role the Insignio could play in terms of people who want to get funding to develop that platform that you can use to then take it forward into something that's much simpler.
Funding, it's a big responsibility, but we're thinking about that. I think that we probably should start to consider building a community in UK and exchange practice, policy. Those who have reliable modeling services start to share them, so that, and that's what we are trying to do now. So in the next 12 months, Insignio is planning to release 7 online services that make available to the research community some of our best things. I don't have a solution, but I have the will to try.
I agree with you in terms of sharing that expertise.
Yeah. There were those 2 gentlemen that have been waiting for a long while.
So my question is basically, when you are doing, let's say you're modeling the outcome of a clinical trial or something like that for a drug study, when you're measuring the effect on animals, let's say whether or not the mice died or lived, that's quite easy to determine based on your input parameters, and it's very hard to make mistakes there. Whereas if you've got mathematical models that depend on a huge number of input parameters, how do you effectively do quality assurance on that kind of on those sort of scenarios to avoid, for example, the pharmaceutical companies, tweaking these parameters until it works, and those sorts of things, especially given that they're not very willing to share data as it is even today, and reproducible research, I'm not sure if that's reached really that area.
It's a very good question. I'll offer you a short answer because the long one would take a week. And it's in 2 parts. The first is there's a whole team of top world-class experts within the FDA that are trying to answer this right now, at least for medical devices. But I know there is another group being set in the EMA to do exactly the same. It is difficult. You have to put some rule in order to avoid what you just said, but it's not impossible. The second part, you gave as obvious something that I completely disagree with. An animal model, if you look what happens in a mouse and you're interested to know the response to the drug of the mouse, then the mouse is the reality. But if your goal is to figure it out what that drug will do in a human, we could debate extensively which one of the 2 models is further from reality, and how many things you can tweak in an animal experiment if you want. Don't develop some expertise or talk to those who... The point is that I regularly lecture about this. A lot of the work on animal models treats animal by analogy. So the implicit assumption is that for the biological process that you're observing, the mouse and the human behave exactly the same. In reality, what we should do is to build an homology that say, this is not real, this is something that represents, is a model. And like every model, before I use it, I have to prove that it's predictive. And this is very rarely done. And that's why 4 out of 5 drugs that pass animal tests fail in the clinic.
Very interesting. Using your analogy between human and aircraft, as you had earlier, and you're designing a program for the average human being, are there standard parameters you can dial in for the variance in the human race, like all the different types of aircraft? So from small to light to heavy, and racial variance within the human race.
We're getting there. We're getting there. This morning I was discussing with one of the postdocs who works with me. We're in a European project. We're working with the Dutch Supercomputing Center to run what it will be one of the largest Monte Carlo simulation for whole body circulatory models, to build a database exactly of this kind. I want to see every single range of parameters that you can encounter in a human being, how it affects the circulatory system. We estimate that we will end up with 1 billion numbers in the database, so it's going to be a big work. But once this number get digested into probability distribution, we will start to go in. But we are 20 years behind other more engineering mature industry. We just started. Yes, thank you.
Can you just say a bit more about the personal health forecasting? I know you sort of touched on this, but things like, you know, measuring your heart rate and blood pressure and cholesterol testing and all this sort of thing, because it does seem that at the moment there's an awful lot of so-called personal quotes devices out there which are not giving accurate answers, particularly, you know, things like the wrist things that measure your heart rate and things, and they seem to have done tests and things which tells you that, you know, that the answers can be wildly different. And so, I mean, that's kind of one issue for the future, is to just how good those devices can ever really get without going into a hospital, as you were saying, and having some sort of properly verified clinical equipment. And of course, the other thing is the whole issue about security of personal data being whizzed around the place, because, you know, there've been so much, you know, so many instances of personal data that's been hacked and so on. So, you know, those seem to be two issues that are quite a big problem. I mean, I should say I haven't really got a medical background, so this is a bit kind of hearsay, but
you know, you're right on spot on both points. You're absolutely right on spot. So I mentioned that there is this consumer electronics which is exploding. I should say that in reality now is deflating. Why? Because some of these companies started to be sued. Yeah. So there was probably the most famous of this company that you were taking your saliva and they would do a genetic test and tell you of which disease you were at risk. Yeah. And then the FDA say, what? What's your evidence about this? Yes. Zero. And so they got really in trouble. But then, you know, we just finished a study on activity monitors. We found two things. First, between different devices, there can be errors up to 300%, which means they are random generator, essentially. The other is that no accelerometer, wearable accelerometer, works for someone who walks at less than 0.5 meters per second. They just don't work. So, for example, in every application related to Parkinson, where the first thing is a bradycardia, so a slower walking pattern, even in early Parkinson, so we need to develop. Eventually, this will become medical device. There will be the toy that you buy when you go running with your friends, and there will be the medical device that will cost 10 times, even if the hardware is probably the same, but behind there is a medical company that has spent a lot of money in testing, ensuring safety, reliability, etc. About the data is a complex equation, and I don't think healthcare is the only one. It's interesting to notice that we technologists are very worried about these things. The people a lot less. Then sometimes these things blow in their face, and then they go ballistic. But it's not a detail. There is a trade. In any case, there is a trade between the risk and the benefit. And we should ask the patients, where is the break point? In this sense, some patient patient organizations, like, for example, the Alliance for Diabetes in UK, in US, are doing an excellent work in working around this technological ethical conundrums. Because I think they are recording. Yeah. That's why. Yeah.
Okay, thanks, Michael. So from your many years of developing subject-specific models, you must have worked with a lot of doctors, clinicians. So how they are taking on with these models, because they are taking risks when they're doing the diagnosis based on the modeling treatment or all sorts of things. What's the best way to convince them to follow this prediction?
That's a $1 million question. Much easier convincing a clinician than a biologist, for example. In the end of the day, a clinician is a bit like an engineer, whatever works. So if you can prove it works, he will not spend too much time philosophizing and how you did it. Where the biologist is a pure scientist, he will never leave you alone. So that's my first bit of experience. Then there are two categories of clinicians. The one I call the desperate clinician. My friend, orthopedic oncology pediatric surgeon in Bologna, who came to me and said, I'm desperate. I have these children. I don't know how to do the rehabilitation, but I have absolutely no idea. Whatever you could give me to help, it's better than nothing. And those are very easy to work with because they are extremely motivated, they're very open, and you progress very quickly in developing the technology. Then there is the mainstream clinical community, and that is very difficult. My belief is that we need to start to inject elements of modeling and simulation in the basic training of medical professionals, because there is a cultural barrier. I'm not the only one who's saying this. He's nodding, and I know many other practitioners who are seeing this problem. So if you really want these things to become mainstream, and this does not apply only to this, it applies to bioinformatics, it applies to image-based modeling, computer-aided surgery, we need to start to train our medical professional, including this fundamental technology in their basic training.
Thanks.
We have time for one last question.
You very kind. You didn't have to. Huh? We could go home.
Well, thank you. I was just curious. Earlier you mentioned about the niches of the models, and I was wondering if there was much work done to combine, to link models to each other?
To combine?
To link models to each other, so you get a more, you get a better impression of the impact on the bigger picture?
Yes. And that is where things get really, really cool. Last year, Modelathon was about combining vascular models with bone regeneration models. So both areas are quite well established. But no, because of the reason I was explaining before, if you understand bone regeneration, you don't understand cardiovascular, and vice versa. We live in paradoxically, we're living the same type of specialistic separation that medical professionals have. If you go in secondary care, you know, the nephrologists don't understand anything about rheumatology and vice versa. We are replicating this pattern, which is bad. So we need to pierce this barrier, because that's where the most exciting things lie. So yes, let's do it. It's difficult, it's very difficult, and it's a teamwork. You can only do in groups, you cannot do alone. But it's going to be very, very interesting.
Thank you.
Well, thanks to you. Thank you.